The screen sharing needs to be enabled.
ECH Talks are live. Please welcome Sharon Allen, Executive Director, World Telehealth Initiative, to the stage.
Hello, I'm Sharon Allen, Executive Director of World Telehealth Initiative, or WTI. Thank you to PQMD for bringing us all together so we can collectively move the needle on global healthcare efforts. WTI was established in 2017 as a solution to address the healthcare delivery crisis. And now we're working with the World Health Organization on a telehealth for the underserved roadmap. We know that half of the world is currently unable to access even essential health services, which results in 8.6 million people dying every year from preventable causes. And to note that half of the deceased received care, but it's substandard. So access alone is not enough. Healthcare also needs to be of high quality. And there's lots of organizations around the world that work to address this issue, but it's usually episodic in nature. Medical missions create tremendous value when they visit the areas of need, but when they leave, the void of care returns. The trips are expensive and they require participating physicians to clear their calendars for weeks at a time. So many doctors simply can't participate. And then other programs attempt to use lower quality technology, yet it's often not reliable. Finally, some that distribute medical supplies don't have the expertise on the other side to ensure safe and appropriate dispensation. So our model starts with the donation of virtual care devices and network access donated to us by Teladoc Health. And since this is a tech talk, I'm going to go a little deeper into the technology we use. It's remarkably different than what many envision telehealth to be when you see your doctor via your cell phone. We utilize state-of-the-art, diagnostic-enabled, medical-grade equipment that allows an enhanced virtual experience. Our devices ride on a proprietary cloud-based network, which allows increased redundancy and decreased latency. And the best part is it utilizes relatively low bandwidth requirements. So we offer the highest levels of connectivity and network performance available, as well as the highest levels of security. WTI continues to assume proactive updates and routine maintenance for the life of the programs. And then that technology is brought to life by a team of humanitarian physicians that are donating their time and clinical expertise in order to care for the underserved. So these components have enabled our mission of providing sustainable medical expertise to the world's most vulnerable communities to become a reality. Accessible, high-quality healthcare is available through our programs for little to no cost for the communities that we're serving. We match the supply of technology and talent to the demand of global needs. And now we have thousands of doctors that are requesting to participate in WTI programs. We use an algorithm we developed to pair the clinical requirements expressed by our partner sites to the available medical expertise. And we consider variables such as time zone, provider availability, languages, even cultural considerations. Um, Oftentimes we match physician diaspora to their homeland. And then we also forge partnerships with entities that are already working in the country. We can ensure that those relationships and support are sustainable and allow them to connect 24/7, whether or not they are on site or in country. Today, WTI has 19 programs in 12 countries throughout the Global South, and the red dots indicate our current program sites. The yellow dots are programs that we've qualified and are in various stages of implementation. We don't have a specific formula. Rather, we believe that the host community should really be the primary driver of our engagement. So they design the program around their needs and resources and their capacity, and then we work to implement it with them. So physicians can provide services in the following four ways. Peer-to-peer didactics is a constant for all of our programs, as WTI's underlying objective is always to increase the capacity of the local providers and health systems so they in turn can care for more of their own community. In this photo, a dental expert in the Netherlands, benefiting from an intraoral camera and image sharing, is able to guide local providers in Guinea as to how to proceed. With scheduled clinical consultations, patients with particular needs that are scheduled with appropriate specialists that beams in at a predetermined time to support the local provider in evaluating that patient's condition. We first partnered with Hope Hospital in Bangladesh as 1 million Rohingya refugees were crossing the border. And as OBGYN and GPs at a maternal hospital, they needed additional expertise to treat the myriad of conditions in front of them. So we beamed in internal medicine, pulmonology, dermatology, critical care, infectious disease, mental health, and more. The next application is surgical mentoring, which allows an expert to mentor a junior surgeon through a procedure. It's usually very difficult for remote clinicians to leave their practice in order to benefit from additional training opportunities, so we come to them. With the zoom capability of the camera, it's easy for the mentor to see the surgical field and guide the local provider every step of the way. The photo here is from our program in Malawi, which resulted in the novice obstetric fistula initially operating on 50% of the patients that presented to handling 95% of the caseload independently after 18 to 24 months of frequent mentoring. So we can even provide philanthropic telehealth services for emergent high acuity use cases. In Argentina, we support 2 remote children's hospitals, and previously these sites would immediately transfer critical pediatric patients to Buenos Aires, which is a 2-hour flight and sometimes resulted in unfortunate outcomes. Now, an on-call expert can beam in and rapidly assess the child. Ideally, they would provide a local care protocol that allows the child to stay near their family, or at least they can help stabilize the child for a successful transfer. So imagine if the 500,000 doctors that are already using telehealth in the US today were to give an hour a week. That would result in 26 million hours annually. And the typical consult lasts roughly 15 minutes, which means we could reach more than 100 million patients every year. And the 500,000 is only including US doctors, but we actually enable healthcare providers from all over the world to participate. So it isn't a stretch to imagine an impact at this scale can be achieved. We look forward to transforming global healthcare together. Thank you.
Sharon, if you could type it into the chat box.
Did you want me to go now? Is that, I'm a little confused
Sorry,
here.
we're having just a little bit of a technical difficulty, it appears. So apologies for that. We do have a few minutes here for some questions for Sharon. Sharon Allen, if you have any questions, please go ahead and type them into the chat box. Technology, when it works, right? Okay, so I'm not seeing, okay. Well, Sean would like to connect with you later, Sharon, but not sure that that's a question for you at this moment. So that's some good feedback, though, definitely. So I'm just wondering, Sharon, let's see here. Mark is asking, do you think that there's a risk in being dependent on healthcare provider philanthropy?
So no, I don't think there's a risk, because whatever we do is designed to build the knowledge and the confidence and the skills of the local provider. So if we were to disappear, the next day, whatever we leave is that knowledge and confidence and tools, for the local providers. So our goal is to make those, our partner sites stronger than if we had never been there. So I don't think there's a dependency. I would call it more of an opportunity.
Great. And we're getting a ton of comments and questions now. I can't even keep up with this rapid fire questioning over here. But mostly we're getting a lot of comments about, how wonderful the presentation was, and so excited. One additional question here: what regions of the world would you like to grow into?
So we do target, low resourced areas. So certainly we're growing a lot in Africa. South America is becoming a focus. And really we're often asked, how do we prioritize? Because of course, many different communities can use programs like this. But we choose those areas where we feel like we can have the most impact. So the partners on site are excited. They have the capacity to bring telehealth into the workflow, and we have the expertise that they're requiring.
Wonderful, great. Well, I know that this was just a rapid fire question and answer. So so thank you so much, Sharon. That was wonderful. I know that everybody here agrees with that. And we're going to flip it over to our next speaker. So thank you so much, and we'll have that announcement coming.
Next, please welcome the director and founder of Project Echo, Dr. Sanjeev Arora, to the PQMD Tech Talk stage.
I'm not sure where that's coming from, but yes, my name is Sanjeev Arora, and I'm going to talk to you about the Echo Project. I'm a gastroenterologist by profession, and the year was 2001, and I had gone into my clinic at the University of New Mexico, and there was a 43-year-old woman sitting in the room, and along with her was a 14-year-old boy and a 9-year-old girl. And I asked her, how can I help you? She said, I have hepatitis C and I want treatment. And I said, of course, we'll do that. How long have you had it? And she said, I've had it for 8 years. So I said, why did you not come earlier for treatment if you have had it for 8 years? And she said, I'd called your nurse and there was an 8-month wait to see you. And she told me I would be getting this chemotherapy-like regimen, and I would have to make 12 trips. I had a 1-year-old child. I was living 200 miles away from you. There was no way I could come to see you 12 times, and there were no specialists in my town. So I said, why did you come today? And she said, I'm here today because I'm having pain here in the right upper side of my abdomen. And I did an ultrasound and found she had a cancer of her liver, which was slightly smaller than a tennis ball. And now it was really too late to treat her, and she passed away 6 months later, leaving these 2 children. So I was asking myself, why did she have to die when I knew how to treat this disease and the medicines were all available in the United States? I'm living in the richest country in the world. And the answer was she died because the right knowledge didn't exist at the right place at the right time. And I enjoyed Sharon's presentation because she was trying to get the same thing. We said the only way to help the world would be to get the right care at the right place at the right time. You have to have the right knowledge at the right place at the right time. And the problem I was facing in New Mexico was there were 28,000 patients with hepatitis C, less than 1,500 had been treated, and they were dying from liver cancers and liver failure. So I asked myself, how should I get this treatment to everyone who needs it? And that was the origin of Project ECHO. And I'm going to share my slides with you. ECHO stands for Extension for Community Health Outcomes. And this problem wasn't unique to me because it was occurring again and again all over the world. For example, 1,800 children die every single day of diarrheal diseases, even though medicines which cost pennies and oral rehydration with salt, sugar, and water can actually save their life, but the knowledge doesn't exist. So at ECHO, our mission is to democratize implementation of best practices for healthcare and education to underserved people all over the world with a goal to touch the lives of 1 billion people by the year 2025. I invite all of you to join us in this effort, and I'll explain what it is. The key idea is to move knowledge instead of patients and providers. And what we do, the model is based on 4 ideas. One is what we call amplification. We use one-to-many video conferencing technology to leverage scarce resources that may only exist in the city or in an academic center. The second key idea is to share best practices. So now the year is 2003. I've started Project ECHO. I went around the state of New Mexico and set up 21 new treatment sites, centers of excellence for treating hepatitis C, each run by a primary care clinician in a rural area or a prison. And I gave them my protocol, but not a single one of them was willing to treat. They said, this is chemotherapy. This is too dangerous. We can't do this. So I said, how did you become an expert? How did I become an expert in treating hepatitis C? When I did my fellowship in Boston, Massachusetts, I would see a patient present to my professor, see another one professor. And after 2 years, they started calling me a gastroenterologist. I said, aha, I'm going to use this model to create new hepatitis C experts in New Mexico. And we would use a web-based database to monitor outcomes. But the key heart of ECHO is what we call case-based learning or iterative guided practice in which all teach, all learn. So in 2003, I started this ECHO model where all 21 sites would join the university in the big box and present cases to each other and to us once a week for 2 hours, every Wednesday from 3 to 5 p.m. And in a 2-hour session, we would co-manage about 8 patients, and then 2 hours, 15 minutes, we'd give them a lecture. And what we found was, over the course of a year, the wait in my clinic started falling, and in 18 months, it was 2 weeks. Anybody in New Mexico now could get treatment close to their home within 2 weeks. Overall, tens of thousands of patients got treated. We started doing research, and we showed that ECHO was improving access, improving quality of care, curing patients, reducing waits to 2 weeks, but it was also producing joy of work. And it was improving professional satisfaction of the rural clinicians. And we did a study published in the New England Journal of Medicine, the leading medical journal in the world, where we showed that these rural imprisoned doctors could give chemotherapy in a rural area of prison and get the same results as long as they joined weekly on an interactive video network. The next step was, how do we help 1 billion people? We said, now we'll do it for lots and lots of disease areas. So we expanded it to all these disease areas: HIV, TB, sexually transmitted diseases, pediatrics, behavioral health, and many, many other problems that are listed here. We now have ECHO projects in 70 different disease areas. We started teaching other universities in the world to do ECHO, and gave them our technology platform at no cost to them and our technical assistance. We currently have 328 publications that show that ECHO works. Doctors like to participate, 256 publications. They're satisfied, 174, 85 showing that their competence increase, and 46 that patient health outcomes improve. The potential benefits of echo are improved quality safety, rapid learning and best practice dissemination, reducing variation, improving access for underserved patients, workforce training, improving professional satisfaction. But we need to democratize knowledge of experts. This is the VA system in the US that has adopted ECHO, 11 academic hubs, connected to 600 clinics for 39 disease areas. These are the universities and not-for-profits that have adopted ECHO. And you can see here 303 US hubs, almost all the major universities in the United States, Harvard, Stanford, UCSF, Johns Hopkins, Yale, etc., are all ECHO hubs. This is our work in Africa, trying to get a couple of 100,000 patients in Namibia on treatment for HIV, India, multi-drug resistant TB ECHO, and globally we have 538 hubs in 45 countries with learners in 179 countries. And here you can see the growth of ECHO. In 2019, we had 229,000 healthcare professionals participating. 2020, it has gone up to 1.3 million as we are trying to train them on COVID issues, how to respond to COVID, how to use ventilators, how to use dexamethasone, how to reuse personal protective equipment, overcoming vaccine hesitancy or building vaccine confidence, training a vaccine workforce, and many, many other things of that nature. So what makes ECHO work is team-based care. Task shifting is the idea of every human being working at the highest level of his human potential. This requires three things: interprofessional consultation, guided practice, and a mentor-mentee relationship. But ECHO is also a community of practice. It's a social network. It's a telementoring network. It produces joy of work. But the key heart of ECHO is what we call all teach, all learn. What we mean by that is that experts learn from primary care clinicians and nurses because they bring the social, cultural context in which patients live. They bring the economic constraints, the barriers to care, and together we create new knowledge to care, produce care, better care in these 179 countries where they work. ECHO is a movement, and I'm inviting you today, every one of you who's joining this network, to join us in this movement to change the world by democratizing knowledge. ECHO is a service project, and I'll end with this quote from Albert Schweitzer: "I don't know what your destiny will be, but one thing I do know, the only ones among you who will be really happy are those who have sought and found how to serve." And this I have found true in my own life, and I would invite you to join us in this effort.
Great, thank you so much.
Go ahead.
Thank you so much, Dr. Arora. Very nice, very nice. Really appreciate that. So we just have a couple minutes here now for some Q&As. I will say before we get started, as you guys are putting those in the chat box there, unfortunately there was just a little bit of difficulty there. Again, technology with your slides. So unfortunately they were not advancing during your speech, but we did appreciate that. And if you are up for it and would like to share those slides could be shared later on our community of practice, but we'll connect with you about that.
I'll be happy to do that. I was moving my slides, but anyway, no problem. We can certainly send you the slides. And my colleague Cynthia McKinney is here. And Cynthia, if you can put your information in the chat box, please reach out to her if you have any if you need to connect with us. And of course, Cynthia, I'll send you my slides to share with them. Go ahead, please.
So any questions for Dr. Arora? Thank you, Cynthia, for sending in your information here. The questions, I know you guys have them. Oh, here we have one. Veronica is asking, what has been the biggest challenge for you during COVID-19 on this front?
I think the biggest challenge is, of course, the demand for ECHO is far greater than we can meet. You know, we are not a for-profit making company. And of course, the challenge is that, there are 6 billion people in the world who don't have the right knowledge at the right place at the right time. And we've experienced 500% growth. And if any of you work for businesses, you know how difficult it is to deal with growth of 500% in 1 year. And so I think it's been a challenge in that sense, but it's also been very gratifying. We think we've reached probably close to 50 million people served just in a year by having training 1.3 million healthcare providers in 179 countries on very simple things. Like, we know, for example, if you do 4 things without any money, you can save lives, right? If you give people dexamethasone with COVID-19, if you give them low molecular weight heparin, like costs almost nothing, is generic. If you put them flat on their stomach prone rather than on their back, you basically can save their life, right? There are simple things because these countries don't have treatment, but they don't also have the right knowledge. And that's what we work on. And right now in Africa, there is so much vaccine hesitancy. And how do you overcome that? And so we train workforce how to have these conversations. And it's been very gratifying, but yes, we are looking for partners who want to collaborate with us, help us scale, and if people have an interest in doing that.
Yeah, we've seen so many changes. I think all of us can feel for that with the technology use during the past year and a half now. Great. So we do have one more question for you here. How do you handle technology issues with your beneficiaries?
We have a rule. We don't make the perfect the enemy of the good. So at any particular point, we have, let's say, 50 learners. Some of them may actually be coming on a cell phone. A lot of Africa, they use their 3G. We use Zoom technology. We provide Zoom for free to all our partners around the world. We have an unlimited license and partnership with Zoom. And we also provide our software for free. And so it operates very well in low bandwidth situation. And sometimes people don't even have a 3G connection, and they can come on the phone and still join our knowledge networks and learn and be mentored. We don't make the perfect the enemy of the good here.
Great, wonderful. Yeah, I mean, I think your point about 3G not working sometimes has been proving for us very much here in today's session, unfortunately. But so just if you guys could all take a moment here to thank Dr. Arora with me. Thank you so much. And Sharon as well. That was great. We really appreciate you guys spending time with us today. I know it was a bit of a rapid fire situation, but we certainly enjoyed it. So thank you so much. And we will definitely continue this conversation on our community of practice. So be sure to head over there for continuing these conversations. Thank you.